hosts. So next, we're going to hear from our Global Perspectives panel, moderated by my colleague, Katie Soros, the Global Advocacy Consultant here at T1 International. So without further ado, Katie, the floor is yours.
Great, thank you, Ian. I'm so happy to be here today, and I'm so happy to be doing this work with our Global Advocacy Network and with T1 International. As Ian said, my name is Katie Soros. I have had type 1 diabetes myself for about 16 years now. And I'm just so excited to welcome you all to our Global Perspectives panel. So today we're going to hear from several of our advocates who are working around the world to address the most pressing needs facing people with diabetes in their communities. And after the videos, you'll have a chance to have your questions answered. So we'll play all the videos before we answer questions, but feel free to go ahead and pop your questions into the chat as they come up for you. I'll read them out afterwards. First up, we have Chelsea Dang from the USA talking about her journey to advocacy after her daughter's diagnosis with type 1 diabetes. So I'll let Chelsea take it away in her video.
Hi everybody, my name is Chelsea. This is my daughter Coral.
Hi.
And we currently live in Los Angeles, California, but we are from Oahu, Hawaii, in the middle of the Pacific. Thank you for joining us. We are here today to talk about affordability and access to insulin in the US. We were born on Oahu, Honolulu, Hawaii, and we are part Native Hawaiian through bloodline, not geographical, Native American, Chinese, and Okinawan. Coral was diagnosed back home on Oahu when she was only 15 months old on March 11, 2016. She would have died from diabetes ketoacidosis, or DKA, if we hadn't contacted her pediatrician with concerns of her wetting her bed and excessive thirst 3 days prior. Shortly after that scary weekend in the PICU at Kapiolani Medical Center, we quickly realized how expensive it is to afford insulin, her lifelong diabetes supplies, along with the cost of living in Hawaii, which is now the most expensive state in the entire US. My husband sought better wages in the mainland, and so we reluctantly left Hawaii in August 2016. A few years later, we had Kyla, our second daughter, who is now 2 years old. We're thankful to have medical insurance from my husband's employer. However, many fellow Americans or those living in the US are on Medicaid, Medicare, or some kind of costly private insurance, if any. We advocate so Cora and millions of insulin-dependent diabetics will never have to worry about being able to afford insulin or risk rationing, DKA, or death. It's a tragedy, and it should not be happening in a wealthy modern country like the US. We joined T1 International several months ago as digital advocates, but have been advocating since Coral was diagnosed in 2016 through social media, our website, and online shop. Our goal by 2040 is to urge Congress to pass legislation nationwide to lower the list price of insulin, break down patent barriers, mandate out-of-pocket transparency between insurers and PBMs. We want this to happen before Coral's 26th birthday or when she's no longer covered by our insurance. As of 2020, at least 1.6 million Americans were living with type 1 diabetes. 64,000 people are diagnosed each year. 5 million people in the US are expected to have T1D by 2050. That number will likely increase due to COVID-19 causing autoimmune diseases in people of all ages. Between 2001 to 2009, there was a 21% increase in the prevalence of T1D in ages under 20. About 210,000 youth under 20 years of age have T1D. The number of newly diagnosed adolescents and children with T1D was already increasing before the pandemic. I want to say about almost every month, a parent of a newly diagnosed child has messaged me on Instagram. Coral's endocrinologist office in Los Angeles, California has also seen an increase in young, newly diagnosed patients. Insulin needs for an adult with type 1 diabetes are typically higher than children or adolescents with T1D due to varying insulin sensitivities, lifestyles, and hormones. Adults typically need about 24 units average a day, while adolescents need about 10 units, and 12 years old or younger need about 7 units average a day. The average cost of one vial of analog human insulin is between $285 to $300. The average spend on a CGM, depending on the brand, for a 90-day supply is between $390 to $1,840. There are 3 major entities that are taking the most profit from patients within the U.S. healthcare system. They are manufacturers, pharmacy benefit managers, and insurance companies. All of them like to point fingers at each other to see who takes the most profit from who. First, let's talk about PBMs in the U.S. Pharmacy benefit managers are companies that manage prescription drug benefits on behalf of health insurers, Medicare Part D drug plans, large employers, and other payers. They negotiate with drug manufacturers and pharmacies to control drug spending, taking the largest discounts and passing on most of the cost to patients. There are over 20 different PBMs in the US. Here are some of them: OptumRx, MedImpact, Magellan Rx Management, Express Scripts, CVS Caremark, and Capital RX. While PBMs are a big part of the problem, according to a 2019 Pew report, manufacturers retain nearly 10 times the amount PBMs make from prescription drug sales. Pew Research Center is a nonpartisan fact tank that informs the public about the issues, attitudes, and trends shaping the world. They conduct public opinion polling, demographic research, content analysis, and other data-driven social science research. They do not take policy positions. The fact that drug manufacturers are making hundreds of billions of dollars off of patients should piss anybody off. We've talked about the issues within the U.S. healthcare system. Let's talk about proposals to regulate PBMs. Policymakers have considered three principal reforms: require greater transparency around rebates, ban spread pricing, require PBMs to pass through rebates directly to patients. PBMs could also base prices on total health benefits and weight of costs on patients' lifelong care or chronic medical conditions like diabetes. Some proposals to improve the U.S. healthcare system include allowing room for innovation, open the market up to new insulin manufacturers. More competition equals more affordability. Look into openinsulin.org, an organization run by type 1 diabetics themselves, manufacturing their own insulin. Knock down patent barriers from big pharma to lead to biosimilar insulins and next generation insulins like Fias, super fast acting, or glucose responsive insulin. We can also write to the FDA to request newer and safe formulas of insulin and medications for ages 4 and up. Legislation should also achieve access and affordability for all, lower and more transparent out-of-pocket costs. Health plans and pharmacy benefit managers should ensure rebates reduce the out-of-pocket costs for all patients with diabetes. Congress needs to lower the list prices of insulin and let patients choose which insulin works best for them.
Join our fight. Visit T1International.com and join your local Insulin for All chapter. Thank you. Mahalo. Have a good day.
Thank you so much, Chelsea. That was a wonderful video. It was so informative, and I really love how you lay out how the structure of the US healthcare system affects insulin pricing in the United States for us. Next up, we'll hear from Sobia Aziz Siddiqui, who is in Pakistan, and her video will talk about some of the issues that the organization she works with is working on there.
Hello everyone, I'm Sobia Aziz Siddiqui from Pakistan. I'm living with type 1 diabetes since 2011. It's a pleasure to be here and present on this wonderful workshop. I'm associated with Meethi Zindagi Pakistan since 2018. Meethi Zindagi, a non-profit organization founded in 2017, is a people-centric organization, valuing the diabetes community as key stakeholder in everything we do. High prices of insulin is a global issue, and the prices of diabetes supply still skyrocketing despite the government claim that they reduce the cost of medicine. Here I mentioned some of the insulin prices. In US dollars, it seems very little, but in Pakistan, these are still unapproachable for various because most of the population here lives under the poverty line. Not only type 1 diabetes community is suffering, but also the type 2 diabetes community is suffering because of high prices of medicines. New technologies are invented for people with type 1 diabetes every day, but still various can't even afford a single vial of insulin. The new technologies here are unapproachable because single sensor price of freestyle liver is $66.04 US. Or for the pump or CGM, people can't even consider. Meethi Zindagi, our promise of insulin program is to provide insulin and diabetes support to the children whose families can't even afford it. Currently, we are supporting 160 children in 28 cities and towns across Pakistan. We are now approaching one by one to various cities of Pakistan. And whenever a child with diabetes of Pakistan is in need, we are inching closer and closer to reach them and support them. We are not only providing support with diabetes supplies, but also spreading awareness for education. Like in various underprivileged areas, there is a huge problem of electricity. So we are also giving them knowledge that how to store insulin in the absence of electricity. Here I mentioned some of the stories. One is Farida, who is from Islamabad. She diagnosed last year. Her mother shared their experience like when doctor told them how much insulin is important for Farida, so they tried their best. But after a few months, they realized it is impossible for them to afford insulin on monthly basis. Aryan, diagnosed at the age of 5. Under promise of insulin campaign, Nitizinki sent messages in different cities. One such message was received by Aryan's family. His father is a security guard, and they said it is difficult decision when you have only $30 in your pocket and you have to choose between food or insulin for your child. Now our organization is arranging diabetes camp or therapy days. In diet camp, we are spreading awareness education to different age people, like to kids, like to youngster or adults, and where they learn about insulin action, food handling, use of technology, diabetes management through various different activities. In therapy days, we also call them tea days, where we sit together and talk about what problems we are facing because of diabetes over a cup of tea. We are very thankful to T1 International because after their guidance, we have now an advocacy team where now we are working on gathering data through surveys to find out how many people in Pakistan can't access insulin and what barriers there are between them and insulin. Advocates from Pakistan also submitted comments with T1 International in support of adding analogs to the essential medical list. And they also mentioned here that how NPH devastated their life or how much they will be grateful if WHO add analogs in their essential medicine list. We are stronger when we are together. So we are very thankful to T1 International who introduced us with various other advocates from around the world. Or we are also thankful to T1 International because they supported us or they also showed us the path to start our journey towards advocacy. They have also provided us the advocacy tools. Thank you very much, T1 International, for your support.
It's so wonderful to hear what Subia and others at Media Zindagi are doing to help care for children with diabetes in Pakistan and educate the community in general there. I just want to remind everyone as well that you can pop for our panelists into the chat box at any point now or towards the end of the presentations. So next, we will transition over to a presentation from Tino Tenda Zikiti in Zimbabwe.
Greetings. Thank you for having me. Tino Tenda Zikiti here present to give the Zimbabwe insulin update. And my presentation will focus on 5 key elements, which are the background of insulin, the supply of insulin, the access of insulin, and the affordability and how I'm advocating towards insulin for all. To start with the background, insulin was firstly used in the year 1960 during the colonial period of Zimbabwe. However, insulin was officially approved in the year 1980, and Zimbabwe has never manufactured insulin domestically, and thus we depend on 100% importation. The Medicines Control Authority of Zimbabwe is in a transition to approve of the recent modern insulin since it started. Unregistered or unauthorized medicines come into the country through unofficial routes. Now moving on to the supply of insulin. Supply of insulin has improved over the years and it still is improving. Both the private and the public sectors are involved in the supply of insulin, and it is undoubted that Zimbabwe has mutual relationships with manufacturers from overseas. Thus, we have proper supply of insulin over the years. Moving on to the access of insulin. The access of insulin in Zimbabwe has not been fully addressed to meet the needs of all the users from around the country. Insulin is regularly available in the urban areas, whereas users in the less remote areas are always found wanting. Patients or carers do have to embark on 200 to 400 kilometers in the hope to access the insulin they need. Inaccessibility of insulin has led to some patients resorting to the then old insulins. Now moving on to the affordability of insulin. Affordability of insulin is a very delicate situation in Zimbabwe. With an average monthly salary of $94, the human insulin ranging from between $9 to $16 a single vial, depending on where you are. Analog insulin ranging from $27 to $30 a pen set. And approximately you need a monthly budget of about $100 to $200 on insulin only. Now, insulin rationing has become part of the diabetic life in Zimbabwe. Patients have and are neglecting to administer their usual dosages at times. Some type 1 diabetic patients have abandoned insulin, switching to metformin, which is a common drug for type 2 diabetic patients. Most patients are not fully aware of the DKA and other complications due to the lack of insulin. Now, I'll share briefly on how I'm advocating towards insulin for all. Through my work with Zimbabwe Diabetes Association, we are fully engaged with the local Ministry of Health and Childcare, and every step and every contribution that we are making is towards the insulin for all, to make sure that everyone else can get the access to the medication that they need, and to realize that insulin is also a human right and not a privilege. And I'm also involved with Zimbabwe Insulin for All chapter, where we are still working on our action plans, which we are hoping that in the near future we are going to have insulin for all as a reality, as we are continuing to getting engaged, working with every board that is advocating for insulin in Zimbabwe or any other medication that we have in Zimbabwe. And currently I'm part of the team that is working on compiling voices from around Africa, 100 voices, that we are going to launch this project on the 14th of November, where we are hoping that it will get the momentum that we're hoping for it to do, so that our voices will be raised, and all these people that are contributing to this are the people that have had challenges with regards to the access of insulin. And lastly, I got involved with Health Action International, where we are also advocating towards insulin for all together with T1 International. And in conclusion, I'll summarize my presentation. There seems to be an inverse relationship between the supply and access of insulin. Supply has improved over the years and it still is improving. Access of insulin has not been fully addressed to meet the needs of all its users. Unaffordability has made people to ration, neglect, and switching to type 2 diabetes medication. And allow me to close by saying, long live to the insulin for all advocates. Let's get involved, let's get engaged, let's come up together and demand the change that we need. Insulin for all and unite for diabetes. Thank you.
We're so appreciative of Tino Tenda and our other volunteers in Zimbabwe who are working tirelessly for Insulin for All. And it's wonderful in that presentation. It's helpful really to hear how Tino Tenda highlights that the issues facing people in rural areas and urban areas are quite different. And that's an important thing for us to remember. Again, go ahead and pop those questions into the chat and we'll transition to our last video from Marian Garcia de Alba from Mexico.
Hello to every member of this amazing global network that I recently joined. I am super happy and excited to be here today, and I feel honored to be able to share my experience with type 1 diabetes in Mexico, which is my country. So I'm going to start by quickly introducing myself. My name is Marian Garcia de Alba. As I told you, I am from Mexico. I was born and raised in Guadalajara, which is a big city, but then moved 4 years ago to Puerto Vallarta, which is in the coast. I was diagnosed with type 1 diabetes 15 years ago, and I'm a realtor, and also I'm a teacher, a preschool teacher and an ESL teacher. So I'm going to run some slides for you and share my screen to tell you how what the current situation here in Mexico is for people with diabetes. There we go. Okay, first, my reason. As I told you, I was diagnosed in 2006 at the age of 18. And throughout the years, I realized how important it was to educate and create awareness around type 1 diabetes in Mexico, since it is almost an invisible disease. People with diabetes are constantly discriminated and rejected for jobs in universities and schools, sports teams, and elsewhere. Mexico's current population is 127.8 million. Out of that, 10% of the population has diabetes, and only 1% of those diagnosed with diabetes have type 1. Diabetes is the cause number 2 of death in Mexico. There's no national record or census for type 1, only estimations. And we have a situation here with the government because there is a lot of corruption, sadly, and the government usually diverts the money that is destined for the public health system, and they steal all the time. I'm going to tell you just about one case that it was huge globally. An ex-governor of Veracruz, which is a state, he diverted 3 million pesos that were destined to help kids with cancer, and they were giving them distilled water instead of what they needed, instead of the treatment for cancer. Just to set an example, to give you an example of the corruption that there is here in the country. Many people with diabetes had to ration food and insulin to survive due to the COVID global pandemic and undelivered supplies that it cost, included me. I had to do it for almost 3 months. And as a teacher and as a realtor, I bump into people that have diabetes and type 1 diabetes specifically too. So I'm going to tell you one story that really, really touched me. I was in the office one day, and this guy, Roberto Carlos, gave us a call to ask if we could help him to sell his house. So we went there, and he told us how in 6 years he lost sight in one eye and the other had blurry vision. He wanted to sell his house for just a few bucks just to get eye surgery and be able to see again. He was taken to an eye checkup and told he needed to get some general tests, and then he was diagnosed with type 1. And as we were helping him out and gathering money and taking him to doctors, sadly, one morning, some people that used to live with him gave us a call and told us that he died. And I'm going to tell you about the costs. The average cost of living with diabetes here is $275 per month, while the minimum wage is $10 per day. 10 millimeters of Humalog are $56. 50 blood test strips, 1-2 Ultra, are $37. And the Freestyle Libre sensors are not always available, and just a few can afford them. You can get 2 for $145. For instance, here in Puerto Vallarta, which is a small town still, it's not a big city, it is hard to get them. They have them at Costco, they sell them there, but sometimes they have them, sometimes they don't, so I have to go to Guadalajara to buy them. And well, the main issues here in Mexico is the lack of proper and updated education, the access to treatment, the government corruption, as I told you before, and that there is no standard practice or system. About the government corruption, almost 80% of the people here rely on the public health system. So it's really sad because they don't usually get the insulin or any treatment they need. And there's no standard practice or system at all. Now, what I plan to do with the help of T1 International and my advocacy focus is raising awareness. How am I going to do this? First, I'm going to start in the schools, because I used to work in many schools here. So I already talked to the principals and they opened somehow the doors for me. And I'm going to run an educational program in schools for both staff and students with an included Diabetes 101 guidebook. In this program, they would learn about the symptoms, how to and who to approach if there are some, diabetes devices and tools, and what to do in case of a low or a high. And this is why if you empower through knowledge, that's how we change things. And that's what I aim for here with type 1 diabetes. Thank you, everyone.
Thank you, Marian. It's amazing to hear what our global advocates, digital advocates, and global advocacy partners are accomplishing in their communities. I'd like to now welcome all of our panelists to the live Q&A. And so if we could go ahead and have Chelsea enter the Q&A. Great. Okay, and now Sobia.
I can't see them.
All right. Hi, Chelsea. Hi,
Hi,
Cora. Hi.
Hi.
It's
Thanks,
great to
Jessica.
see you both. Yes, thank you so much for your video. We'll go ahead and get Sobia into the panel as well. Here she is. Hi, Sobia. So good to see you.
Really hard.
Hello, everyone.
Thanks for being with us today. All right, we can bring Tino Tinda in.
I think I saw a question in the chats about the monetary comparisons in each country, the monthly income in each country.
Yes.
I wasn't able to go into detail with each individual state's average or medium income, I should say, for the U.S. compared to, cost of insulin, because, it's way more complex in that there's only about 11 states within the U.S. that have insulin price caps within the whole 50 states in the U.S. So I did compile parts of research for that separately, and I'd be happy to answer that more either on direct emails or on Instagram or Twitter when we have more time. I'd be happy to answer that question with the direct sources.
Great. Thank you, Chelsea. That's something that your presentation really gave us a great overview of, is how different it can be state to state and insurance plan in the United States, which is complicating. And I just want to go ahead and welcome Marian as well to the panel. Good to see you. Great.
Hi, thank you.
So thank you, Chelsea, for going ahead and answering that question. I'm just going to read it out for the other panelists as well. So we had a question from Allison that many of the panelists mentioned the monthly cost for insulin and or diabetes supplies. Could anybody else in the panel, Tino, Marian, or Sobia, talk about how that compares to the average monthly income in your countries? And anyone can start. I know, Sobia, you mentioned this in your presentation as well.
Yes, I mentioned it. For example, I mentioned one of the slides, like one person monthly income is about $120 US, or the cost of insulin they are spending money on insulin is about equal to, if we compare these ratios of $35 to $40 with the monthly income of $20, so it is so hard for them to manage their diabetes supplies or for their other household things. So it is.
Sobia, I think we're having a little difficulty hearing you. If I think it might be helpful
for them to maintain.
Hopefully some people heard you, Sobia. I was having a little trouble. So if you could type what you just said into the chat box, maybe while another panelist answers, I think that'll make sure everybody can hear your answer. Thank you so much. I'm going to mute now.
Oh, hello. Thank you. It's not in the here present. So I would say I greatly concur with what Chelsea has said. It is very difficult to come up with average monthly income of any other country, as it is compared to how you can get the cost of insulin, because it is known, because you can actually go to the counter on a pharmacy and you get the price, but then it varies. But I would just have to mention, I know that Liz will be able to share a link that I gave to her. So basically I would say 250. And then, but I said that during my presentation that for the cost of insulin, it could go as much as 200. And then your monthly salary is 250. So, which is going to be very difficult for you. You'd have less, maybe $50, remaining with $50 after insulin only. And you have to care for other people in the family. So yeah, it's a very difficult question, but yes, it's a very critical one. Thank you.
Thank you, Tino. Marian, do you want to add anything to this question?
Yeah, thank you, Katie. Well, I would also say that I added some of that information in my presentation, and I'd be happy to share more in a direct link. But same situation as everyone, I guess. It's really, really hard for people. There's a lot of poverty here, and it's super hard for people to access insulin and all of the supplies that they need. So if there's, I'll share another link with the information with more numbers. But yeah, it's almost the same as everyone else here.
Thank you. And that variability makes it really difficult to talk about this in many ways. And that's, I think, part of why we're all doing this work in our own communities. I'm going to go ahead to a question from our general audience, because I know that staff popped one in, but we'll just make sure we get through this. So what does the organizing and advocacy look like in your countries? How responsive is the local and federal government to hearing from you? Anyone who wants to add related to that question?
I can only speak on a personal level to this. I can't quite speak to each individual family because, again, it varies so vastly across every income bracket, every household, and it depends on, like your level of education and what you got access to. Hospital care is just, the healthcare system is really broken here in the US. I mean, they're charging $300 a vial for human insulin here. And given the climate of how it is with the government in the US, I'm sure you've heard it across the globe. I hate to say it, but we are very divided in so many levels, and it's very disheartening. So trying to get our voices through this static, I want to call it, it's difficult to reach out to the government because you've got division between the Republicans and the Democratic parties on, this global pandemic, how they're handling it or mishandling it. And then you've got the healthcare crisis, with diabetes being this epidemic that's been going on for decades. And so trying to get, to amplify each other's voices just on a social platform, and then trying to convince everybody, hey, please go to these links, read more about it. I'm constantly referring people to T1International.com because you guys are like one of the only biggest nonprofit organizations that does not take money from big pharma. And so if more people could help us advocate, become our allies, which means requiring action, write to your senators, write to your governors, email your hospitals, whatever it takes, take baby steps. Start from your healthcare providers, help them become your advocate, and get them to email the FDAs about big pharma, and maybe get samples in your office. Some endocrinologists are able to get samples, even if it's just 1 pen of long-acting or rapid-acting insulin. Email them. It takes a lot of perseverance, and it takes a lot of self-motivation and research. And that's something we did a lot the week she got diagnosed back in 2016. My husband's a former medical professor, so we know how to find these resources, but a lot of families don't. It's also why I started my info blog, my website, is to list all these resources. I put T1 International on there as well. There's also getinsulin.org. And I know this is a lot of information, but just really get your voices out there and help share each other's stories. And I found Twitter to be a lot more effective than Instagram, frankly, because you can actually put hyperlinks, clickable links with each tweet, and people can go to that and then retweet it and reshare it. And you can tag your governors, because a lot of governors and senators, they're on Twitter. They're not on Instagram. And a lot of these physicians, they're on Twitter. They're real physicians. I've looked them up. I go to see where they went to college and everything. Like, okay, this guy's legit. So that's just one way to get your voice out there in the simplest, fastest way. But it does take more action in emailing your governor. And frankly, they don't hear us. They're not hearing us. Mm-hmm. It's been 100 years. They're not hearing us. So I'm tagging the president. I've literally tagged POTUS multiple times. I'm like, hello, I'm right here. there's people dying, you know? So sorry,
Yeah.
I'm going on.
No, thank you, Chelsea. It's so important to highlight how this is long-term work and it requires a lot of different strategies, and some we won't know which ones are effective, right? But we keep moving in all these different directions. I have seen that Sobia, we dropped her from the panel accidentally, or she accidentally got dropped, but she says that insulin access varies in urban versus rural areas. Besides insulin, they're also facing problems of not having much medical centers, hospitals in their areas, or some or no pharmacies in rural areas. Very unfortunately, we have to close this panel up, but I do just want to take 30 seconds if Tino and Marian each want to add anything related to their local governments or federal governments. And the chat is also, you could type in more if we want to.
Yeah, I would like to add something really quick, Katie. Thank you. As I mentioned in my presentation, here in Mexico, there's a lot of corruption from the government, but I'm going to talk from my own experience with my endo and my state. They have canceled many camps and campaigns that my doctor has done. So it's really, really hard. There's not a lot of support from the government, and they don't buy insulin or supplies for the public health system since last year. So it's really hard here in that matter.
Thank you, Marian.
Thank you. All right, so I'll go. I just want to drop something. Of course, Shosi mentioned something about this. Yes, the advocacy in Zimbabwe, one thing you have to know, maybe people can just take this up as a note to say, before you go and start your advocacy, you have to research, you have to know what the government does, what the suppliers are doing in the country, so that before you go in and start to do your advocacy, maybe you might be starting to tackle things that are already addressed. But then it is very toxic with the policies that we have in Zimbabwe. You cannot just go with a placard. You would spend the night in prison. You cannot go because the policies that are put up there are to protect, maybe because they don't want people to be going outside advocating, but then advocating online as it is right now, I think it is going on well, but then you'd have to mention the facts, the things that they're doing well, and to say, okay, fine, we can improve in such an area. So then with things, we just have to go on well. So yeah, that's basically what I had to say. Thank you.
Thank you, Tina Tinda. Thank you, everyone. We do need to close our panel now. If Sophia or anyone else has any other answers, please, panelists, go ahead and type those into the chat so we can all read them. Thank you all so much, and we so appreciate your work and your efforts.